Welcome to another episode of the Fertility Podcast. Still not quite there with my voice. Can't shake this cough. If you're going through an annoying summer cold as well, I do feel for you. Now, before I share today's episode, do me a favour, rate and review this podcast. Just grab your phone and click through on the podcast app that you're listening on, or if you're already in iTunes, and a lovely 5-star review. I think I'm on about 90, and if I can get to 100, that'd be lovely. So that's like 5 of you, or even if you want to do it 5 times, just to let me know that you like what I'm waffling on about. It's coming up to 4.5 years of doing this podcast. I was thinking about what I should do for my 5th anniversary. So any ideas, feel free to let me know. It's natalie@thefertilitypodcast.com. And the other thing that I just wanted to remind you of is, if you're in the north of the UK, we, as in a group of fertility peeps that we're calling ourselves Talk Fertility, and I've mentioned it on this podcast before, we're doing a male fertility event on Wednesday the 12th of June in Manchester, and we've got an amazing host of experts. We've got Dr. Mohammed Akhtar, who's a specialist in male fertility, Robin Hadley, who talks about living as a childless man. We've also got Dr. Michael Carroll, who's amazing at talking about the environmental and lifestyle effects that impact sperm health. And we're going to be welcoming Jack Broadley, who is the founder of Baggy Trousers, which is a charity raising awareness of testicular cancer. It's all about checking your nuts. And Jack and I connected, and he told me how he gets a lot of men kind of talking about their concerns about their fertility when it comes to fertility preservation. So that's something that we're going to be talking about. Now, each ticket is 2 for the price of 1. So basically each ticket is for 2 people. So if you're a little bit intimidated at the idea of coming to a fertility event, then just grab yourself a ticket. The details are in Eventbrite, and I'll put the link in the show notes. So make sure you're listening to the end of this episode, and you can bring someone along with you. Or if there's no one that you can get to come with you, we always have a little WhatsApp group where you can get in touch with us, and we'll make sure that you don't feel alone, because these things are a bit daunting, and we want to make you feel as welcome as possible. So make sure you're listening to the end to get all the details that you need. The episode you're about to hear is a really interesting conversation, of course, it's interesting, with Dr. Phil Boyle. Now, Dr. Phil Boyle has a restorative approach to reproductive medicine, and I was keen to talk to him about his approach, which he's been developing and writing papers on, and especially how it helps older women who are later to motherhood. So have a good listen to him. Before we start the chat though, here's a couple of messages from my sponsors who make this podcast possible. You'll know that I talk a lot about support on this podcast, and that's why I'm really chuffed to be working with one of my sponsors, Apricity. They offer extra fertility benefits at no extra cost. And when you start your treatment with Apricity, you'll benefit from support and guidance 7 days a week with your very own Apricity advisor. Plus, there's an app to keep you in the know every step of your fertility journey. And you know what? You pay the same as you would at a clinic. Find out more at apricity.life/podcast. Another of my sponsors is International Andrology, who specialise in diagnosing and treating male infertility. Around 50% of infertility issues are male factor, and all too often, men aren't even evaluated at the start of a fertility journey, which might result in unnecessary treatments, costs, and disappointment. International Andrology is one of the few specialist clinics in the UK offering a holistic approach to increase your chances to conceive naturally or via the IVF route. As well as treating the underlying causes of male infertility, their doctors have some of the highest success rates in microsurgical sperm retrieval. So, if you're looking for a true specialist to assist you on your fertility journey, visit london-andrology.co.uk today, and do mention the Fertility Podcast. I'm now going to welcome Dr. Phil Boyle to the podcast. He's the developer of Neo Fertility and a fertility doctor. He's also a member of the Irish Fertility Society and president of the International Institute of Restorative Reproductive Medicine, which we're going to find out more about. Dr. Phil, welcome to the podcast.
Thank you, Natalie.
Just The use of the word restorative fills me with hope. So can you tell me a bit more about your approach? Because this is a new treatment that you're behind, isn't it?
Yeah, our thinking is that if you're not getting a successful pregnancy, if you're either getting miscarriages or experiencing infertility, then there has to be a reason for that. And we have evolved over the last 20 years of clinical experience that I've been doing this, and we've identified more and more additional factors that are contributing to the overall title of subfertility, meaning either infertility or miscarriage. And we're of the view that infertility is rarely caused by a single issue, and it's usually multiple things at the same time, all working together to impair fertility. And the challenge for us, for each individual we see, is which factors are most important in your case. So there are recurring themes, but then there are issues that are unique to each individual that you've got to look out for. And for us, we've got around a dozen or so different things that we consider for every couple that are hoping to try and conceive.
So more often than not, are individuals or couples coming to you having had failed attempts?
Yes. So about a third of the couples that we see have tried and failed IVF, and somewhere between 20 to 25% are told IVF is the next step. So we're getting people very much at that bracket. But what you have to remember, IVF was developed for blocked fallopian tubes, where you can't get pregnant because the tubes are blocked. It's also been shown to be helpful for very severe male factor infertility. So if there's even a reduced sperm count, we can often work with sperm counts in and around the 5 million plus. We're confident we're going to get there. And if we have at least one fallopian tube, then we could work with that. We don't even need 2 fallopian tubes. And often we go for surgical reconstruction, but they're the main areas: severe male factor and blocked fallopian tubes, where natural probably isn't a good option, and in vitro would be a better option. But the vast majority of people that are doing in vitro fertilization don't need it. And controversially, Professor or Lord Winston has said this repeatedly and generates a degree of controversy about it. But I think where he falls maybe a little bit short is, well, what is the alternative that we can do? And I don't think respectfully he's aware of a lot of the new things that we've actually started to do with this, because, well, we need to publish more. We don't have enough publications yet. We've grown more through clinical experience.
Well, let's talk more about these other ways, because sadly, a lot of the people I speak to have been diagnosed with unexplained infertility, which the term in itself leaves people in such a state of stress because they don't know which action to take. And there's all the controversy around add-ons, and the emphasis that you put on things like diet and hormone balancing that people can take hold of and empower themselves with more knowledge about seems to make much more sense. So can we just talk a bit about those steps that you help people along with?
Well, the very first step in anything medical is to establish a diagnosis. I think it's hugely unacceptable to have this unexplained infertility. It means, well, it's not being assessed in a thorough fashion. And what we go right back to is, well, what are the signs, the natural signs that your body shows that you're fertile? And especially with respect to the female cycle, well, she gets a menstrual bleed. She gets a few dry days where there's no discharge. And then she gets the fertile discharge, which most women are familiar with. The last day of that visible mucus or discharge is presumed ovulation. And then if she's not pregnant, about 2 weeks later, her bleed comes on. In addition to that, she should get a temperature rise. And what we like to measure is get somebody to document all of these things in a systematic, precise, methodical fashion. And our fertility app is helping a lot of people to do that. So when people get that information, we can see the bleeding pattern, their mucus flow, the presumed ovulation day, the length of the cycle, and we can see a lot of things even before we do a blood test. And I've seen so many who have a previous diagnosis of unexplained infertility just by simply documenting what their body is telling them and showing us their fertility pattern. We can see it jumping off the page where the problem lies. So that would be the very first step that I'd recommend for most people. The second step, absolutely, that is diet, nutrition, and supplements. So common pro-inflammatory foods for us are too much dairy, too much wheat, and too much sugar. So as a broad strokes anti-inflammatory dietary strategy, if you're having your brown bread with a slice of cheese, a glass of milk, a bowl of Weetabix, you're overloading on all those problem foods. Better to go for porridge made on your skimmed milk. Skimmed milk is actually fine. Water, your fruit, your nuts, and go away from the wheat dairy side of things. In addition to that, people may have a multivitamin deficiency. So we go for a very good broad multivitamin. One of our current favorites at the moment is the Conceive, because it's a sachet. They pour it into a glass of water, they mix it up and they drink it down, and it's loaded with everything, but you could be very confident these nutrients will be absorbed because they're dissolved in liquid. Now, some people do find it hard to take, and in which case we'd say, we'll go for the capsules. They're not as strong, but they will still give a whole range of the multivitamins we're looking for. And there are some concerns with capsules because there are multivitamins, you take them, they go through your system and they don't absorb so well. But the reason I like this one is it's research-based in terms of there are publications that will show zinc, selenium, magnesium, and all these trace vitamins, minerals, elements will improve fertility. So they've put all those together in one supplement, and I tend to recommend it anywhere between 3 to 6 months. A good number of people aren't nutritionally deficient, and we tend to overtreat a little bit with that, but that's our simple way of doing it, where we'd say, well, if we suspect you may be deficient, let's make sure we've covered that. So we've got diet and supplements. And then the other thing as an overall concept for people is, it's a very frustrating thing when a friend tells you, well, just relax and it'll happen. But there's more truth in it than people would care to recognize, because it's like, how can I relax? This is so painful. This is so traumatic. This is, we really want to do this. And it gets really annoying when people say that. But rather, what we're looking for is what we refer to as surrender and acceptance. A little bit like bereavement. Nobody likes or wants bereavement, but it happens. It's a fact of life. So we accept and surrender to something that is very unpleasant. And somewhat the same when you're really trying to conceive. If you actually carry that burden too much and try too hard, it becomes self-defeating. So our strategy to achieve success is to say, today is the day we drop that burden, because we want to get success, and carrying that burden is going to hinder us. Some people need help to get that, and there's various levels of help. We go for the likes of organic conceptions, which are an American-based group that do self-help to help people understand and recognize the reason you feel awful is because this is awful, and that's okay. And here's how we live with the trauma that this is, and here's how we help to move to acceptance in the hope that we may still get success. So they're very good. If that isn't enough, because that's more of a self-help thing, then we up it a notch to the likes of counseling, and a properly trained counselor who really understands this is important. But you have to recognize the emotional, psychological trauma of subfertility. It's right up there with bereavement, and not every counselor appreciates just how that is. So that's another big thing for us. So our strategy for people is get a proper assessment, document your fertility pattern, look at your diet, nutrition, and supplements, look at your relationship, your heart, mind, and emotions, and be liberated from this burden and laugh, relax, and enjoy during the favorable time. Then we start to look at the other things. And there's a real interesting one that we're doing with hormones, where we say that the usual test for hormones is you check your day 21 progesterone. If it's above 30, then you're told you're ovulating. Well, guess what? If you have a monthly cycle, you're ovulating. A blood test really doesn't tell me a whole lot more. Women who don't ovulate won't have a monthly cycle. And our question isn't, are you ovulating? We've got a contrary question that is not practiced ordinarily in this field of medicine, where we say, but what about the quality of your ovulation? So it causes a degree of confusion and head scratching and saying, well, what are you talking about? And we would insist, if we know the day that you're presumably ovulating with the help of your fertility pattern from your, say, the Neo Fertility app, and we time our blood test for 7 days after that, we measure a combination of progesterone and estrogen. We use a higher reference range than the day 21, and we look at 2 bloods instead of just 1, because it's progesterone and estradiol. And with that, we're able to interpret the quality of ovulation. We would insist blood timed at that stage, progesterone should be above 60 and estradiol should be above 400. And if it's in that zone, then we go, that's an optimum ovulation. where you're more likely to get pregnant and you're less likely to miscarry. But it's solid. In the subfertility world, 8 times out of 10, we'll find that we're getting suboptimal ovulations. And that's a real important one for us to get right as well.
And can I just ask that if you've taken that blood test and it isn't optimal, that the things that we spoke about, the diets, the supplementation, can all then impact on a better result, we'd hope.
Yeah. Sadly, that wouldn't be enough to correct hormone deficiency. We see some modest improvement in it, and we'd see that these factors that had been pulling against fertility as part of the multifactorial strategy, if you're young and you still have suboptimal hormones, you can get away with it just doing these things. But as age advances, then you need to be more precise about going for hormone-based treatments in order to bring those bloods back into the normal range.
I'm interested in just picking up on the age comment that you just mentioned, because I know from the research that you have been doing, there was a paper that you had published last July. I wanted to talk about the hope that you have found for women hoping to have children later in life, as the study that you did had an average age of 37. Is that right?
Correct, yes.
I know from the audience of this podcast that often that's the age that we are at, be it having been trying for some time, be it, life has meant that we're not trying till our late 30s. So what fresh hope have you found for women who are thinking about starting their families later?
Well, we go from the average to the outrageous when it comes to fertility treatment, and on an individual basis, you can never predict which individual will get success or failure. But somebody who has really pleased us through our practice, she came to us at the age of 43 with 5 failed IVF, and she delivered her baby at the age of 44, her first baby.
Is that with her own egg?
Oh yeah, because we're natural, so
right.
It's all with your own eggs.
Okay.
So that would be the more outer end of the scale of what we can get, and we wouldn't get 100 pregnancies for 100 people with that kind of a picture. So what I often say to people, there's an age-related graph that we have that's actually on our website as well, and it shows the natural decline in the expected live birth rate with advancing female age, so that you can look at your age and see on the graph, and there's a graph for the expected live birth rate with an IVF, a single IVF cycle, or the expected live birth rate for a year of natural conception with balanced cycles. And across every age group, what I see is the expected live birth rate for advancing female age is higher for natural conception compared to a single round of IVF. The only difference is it's a year of natural conception, which is head-wrecking for us as well as people we treat. And I had a couple who was with us, and she had this magic 35. I'm 20 years doing this. Nobody worried about age till they were 40 when I started doing it, but everybody has a degree of panic now at 35. But the number of 35 is primarily because of the IVF data. And IVF data, the HFEA in the UK have the official data, but you have to look very, very closely because it's for 100 women who start a cycle, how many have baby in hand at the end of it? And that's where you got to look closely at the numbers. It's roughly 1 in 3 for women who are below 35, and it's down to about 1 in 10 by the time you're 40. So the numbers dramatically decline with advancing female age. But what we'd observe is the expected live birth rate in those same age groups in the general population for natural conception is way above those numbers. And our thinking is, and what we've observed clinically, if we implement a restorative approach with multifactorial treatments to get you healthy, get you happy, get a balanced cycle, get hormones in the normal range, but then validate that with ultrasound scans to visualize that ovulation is definitively happening, work on the male factor as well. And then for those who need to, we refer for surgery as well. And you can have silent, symptom-free, hidden endometriosis, but you need to find the good surgeons that are capable of identifying and treating that, which is a real challenge as well. So with that multifactorial strategy, what I have found is for those who are going down the road of fertility treatment, they get anywhere from 3 to 6 months, for example, of Clomid. And that isn't as widely practiced as it used to be. Because it used to be given for so-called unexplained infertility, even if your day 21 progesterone was normal. So that is dropped from common practice, where it's not even attempted anymore. And Here's the part where there's a bit of a disconnect on two levels. That, well, first of all, establish the diagnosis and correct it, and 6 or 3 cycles isn't enough. Everybody agrees it's normal to take a year to get pregnant. So if we find and fix multiple factors, then we say, now we allow it to happen anywhere within the next 12 cycles. So that part is important for us that a lot of people tend not to do.
I'm really interested in whether this is down to our perception, in that when people think about having fertility treatment, more often than not, they think that they're going to ultimately have IVF, whereas your approach with this restorative approach and looking at these different factors that we've discussed is still ultimately fertility treatment, because you're treating somebody's fertility. And I think that we've kind of got confused in what we're calling things, and people aren't realizing that this part that you're doing is as significant, rather than people being rushed into having an IVF cycle, not being ready physically or mentally, and ultimately it failing, and then going through ongoing failed cycles. As your case studies highlight, people are going through, sadly, numerous failed cycles, IUIs, miscarriages, and then coming to you. And I know one of the comments that somebody said was that you had actually said they'd probably end up diagnosing themselves. So I'm assuming that the way that you're educating people in all of this stuff, they're obviously going off and finding out more, which I know we do in this TTC community. We're hungry for this information, but you're practically and actively supporting people making these lifestyle changes with your natural approach, aren't you?
Absolutely. And again, being very blunt and direct about what the percentages and the numbers are, I would love 100% for everybody, but I'd say, well, look, here's the age graph for natural conception. Here's how your age matches up. So by the time in the general population aged 40, you're going to get a 40% live birth rate, believe it or not, which is higher than IVF at the youngest ages. And often for us, where there's this real concern about advancing age, well, yeah, because if we're looking at natural, it's 80% when you're 35 naturally, so it has come down. But even at age 40, we still have a significant number who can achieve success. So what we'd explain is there's genetic aging that's pulling against us here, because genetically the reproductive system ages faster than the rest of ourselves. But there's a whole load of other things that happen at the same time, where if we cover all of these other factors, then we can compensate to a degree for advancing age, where we correct things like adrenal fatigue. We sometimes look for food intolerance. We sometimes go for antibiotics for treating chronic infections. We have a beautiful treatment with something called low-dose naltrexone, which boosts endorphins and ultimately has an immune-modifying effect. But many women who are plagued with painful periods, low mood, anxiety, fatigue, premenstrual symptoms, they dramatically improve with low-dose naltrexone, and then our hormone fertility treatment works better. So it's very satisfying from a physician point of view, because even for those couples that we don't achieve success with, there's a degree of acceptance and satisfaction. You know what? We have really given this a thorough assessment, a really good shot at it. And sometimes, despite our best efforts, it's going to escape us. So if people are aware of that, and I often say, well, you own the decision when it's quitting time, because the NICE guidelines in the UK will tell us that, yes, it is normal to take a year to get pregnant, but couples who aren't pregnant at the end of year 1 of trying, if they do nothing other than persist for a second year, up to 50% of couples will conceive in year 2. So in fact, it may be normal to take up to 2 years to get pregnant. We use the 12 cycle guide as the traditional a year, then you fit the definition. So let's do a year of balanced cycles before we give up on it. It's a suggested, soft, flexible stop date, because all we've done is restore balance. You're producing 1 follicle, releasing 1 egg, normal physiological function. So there's no risk for women taking this on a long-term basis, because it's about balancing where the deficiencies are. But it's just in and around the 12 really good cycles completed, I'm becoming less confident that we may have the solution for them. But we do up to 4 or 5 cycles beyond the 12 for those who aren't ready to stop. But often it's a gentle suggestion, maybe we have done enough. So it's a nice adjustment to it on one level, and some people feel they've got to try IVF, and that's always their call to make, and others it doesn't appeal. So it's always up to what the couple want.
So would your ideal be, if a couple have been trying for a year, and which is normally the point that they go to the doctor and then potentially get referred?
There.
Sorry?
sorry, apologies, but I would even interrupt even there, that if somebody is thinking that maybe they might like to attempt conception in 3 months or 6 months, you don't have to be in the midst of we're trying. You actually lay your foundations before you attempt conception in the first place. So if somebody develops their fertility awareness by documenting all the signs of fertility, then the fertility chart, especially with one of the fertility advisors or teachers who provide instruction, and even within our app, we've got a questions and answer. If somebody has an unusual pattern, we'd say, I know you haven't tried to get pregnant yet, but you know what? There are big red flags here. Your bleeding pattern isn't right. Your temperature surge is poor. You've got all these negative symptoms. You know what? You should see a restorative doctor who can help you to restore this even before you attempt conception. So for us, fertility is a problem even before you try to get pregnant. You don't need to be a year trying, and you don't need to have 3 miscarriages to say there's an issue. We can see it coming before it happens with documenting the charting pattern.
You did mention earlier about the lack of papers published. If people are listening going evidence-based, I want it to be evidence-based, is there, I mean, I know you've mentioned some of your success rates. Is the proof in the pudding?
Well, for me, I've got my clinical experience. We've got over 3,500 successful pregnancies. Up to a third of those have tried and failed IVF. The paper that I published was to try and look at, if you like, resistant infertility, where they had an average of 2 failed IVF cycles, an average female age of 37. We looked at, so for example, we looked at everybody who tried and failed IVF before they came to us. But I looked at old data, because our current data is even better, but this is our oldest data, so it'll hopefully be the lowest numbers that'll come up. At that time, one of our challenges was people would do 3 months of balanced cycles, they'd lose the plot, and they'd get distressed and they'd quit and they'd go away and wouldn't come back. In fact, I had somebody like that recently, and they came back after 2 failed IVF, having done 3 balanced cycles with us, and they just, intensity got to them. But they realized, well, IVF wasn't the magic bullet they thought it would be. And thankfully, they're now currently pregnant. We got another 5 balanced cycles, and they're well on the way now. But in terms of evidence, there are different levels of evidence. So you start with clinical experience, and that's the level of evidence that we've got. So we don't exaggerate our evidence and say, we've got these definitive publications, everybody needs to go this direction. But we're working towards that. So this group that I'm currently president of, the International Institute for Restorative Reproductive Medicine, our mission is to get more data and bigger data and publish it in peer-reviewed medical journals to convince our peers who work in this area that we believe infertility is a chronic condition. IVF treats it like an acute condition. Chronic conditions need multiple sustained interventions over time, whereas an acute condition is a single quick thing like an IVF cycle. And we say, if we pay attention to all the facets, then except for those cases where there's extreme male factor or blocked fallopian tubes, most couples with infertility will have a higher probability of getting pregnant, singleton pregnancy, full-term healthy baby, healthy mum, will get higher percentages going that route rather than going for an IVF route that doesn't pay as much attention to the underlying reason why this isn't working in the first place. The publication we have was to try and challenge established thinking that where it's perceived among physicians as well that IVF is the gold standard, it's the treatment to go for. But if you stop and look at the numbers, they're a bit depressing in and of themselves, even though there are wonderful pregnancies from it as well. But our publication was to challenge that and say, you know what, there's a restorative option. And with our paper, we said with life table analysis, looking at our data, we got a 32% success rate for couples who had tried an average of 2 failed IVF and a female age of 37. So we picked the most difficult, but an average for most people on a population basis, we're running around a 50% success rate. And I often say, well, there's percentages and then there's people. For you individually, it's going to be 100% or 0%. But on a population basis, here's what you can expect your probabilities to be. So remember, we're not in charge of this, neither us nor you. What we do is let's make this environment as favorable as we can. and allow that fertilization may come into this pleasant space that you've generated from a medical, emotional, psychological point of view, and just bring them along that. And also, well, accept the real possibility that sometimes this is beyond us. And when people get to that surrender and acceptance, that can sometimes help them to get pregnant as well.
Well, I'm going to put all the details of Neo Fertility on the show notes for this. Dr. Phil, it's been really interesting hearing about this alternative approach, because I know that my listeners are so well informed and they want to know every option. And I think the more we can get the word out there that it isn't just one route and it's not at all one size fits all, we know. And people want to know their options and not be rushed into things and have this information to hand to try and implement and make these changes. So thank you for sharing. I will put the details of the app as well. We're always happy to give people the physical tools, because we are obsessed with our phones, that we can have in our pockets to help us, understand more about our fertility. Thank you for your time.
Very welcome, Natalie. Thanks for having me.
It's always my mission to give you like another viewpoint, another way to approach your treatment. If you're trying to conceive and you're not convinced about going down the IVF route yet, or if at all, there are all sorts of different options. And what you just heard Dr. Phil Boyle explain was a really different approach, which I wanted to give a bit of a spotlight to. So the show notes for this episode to find out his details are thefertilitypodcast.com/Neo Fertility. In there will be the Eventbrite link for the men's fertility event that Talk Fertility is putting on in Manchester on the 12th of June. Also, just my social media, which is at FertilityPoddy. If you want to follow me on Twitter or Insta, it's always amazing to hear from you and chat with you. Thank you, as always, for your support. And until the next time.